Lucas, you are on mute. If you could turn on your mic.
Sorry.
Oh, now it's perfect.
Okay, so once again from the beginning. Good afternoon from Belgrade. Good afternoon from Serbia. It's my pleasure to welcome you to the 5th webinar of the ENS Peripheral Neurosurgery section. Establishing of the ENS section of the Peripheral Neurosurgery was officially confirmed in the ENS General Assembly in Venice in October 2017. Since then, the ENS section of Peripheral Neurosurgery has been intensively working to promote peripheral neurosurgery and thereby encourage even more surgeons to start participating in this exciting area. To raise interest in this field and awareness about the importance of the peripheral neurosurgery, all members of the ENS Peripheral Neurosurgery section are dedicated to continuous medical education and participation in webinars, congresses, publishing processes, and intensive promotion within national and continental societies. In the pandemic era, we have remained active and even intensified our activities. I would like to mention that ENS Peripheral Neurosurgery section members held the very first ENS webinar dedicated to peripheral neurosurgery on September 9, 2020. One of our webinars in the previous period was organized as a joint venture with the WFNS Global Neurosurgery Committee, which attracted great attention among participants worldwide. Today's webinar is about peripheral neurotumors. Peripheral neurotumors comprise a fascinating group of heterogeneous lesions that challenge our diagnostic and therapeutic capabilities. Our management of this lesion has progressed substantially in recent decades through the pioneering efforts of our colleagues in many disciplines, but many controversies and challenges remain. No longer do we accept the routine sacrifice of the functional nerve fascicles when resecting benign nerve sheath tumors. However, even the most experienced and skillful neurosurgeons do inadvertently injure nerves occasionally when removing certain difficult lesions, even when benign. Recognizing and dealing with potentially malignant lesions is even more challenging, and we have not even reached uniform agreement as to when a biopsy is mandatory prior to tumor resection. Imaging has improved substantially for these tumors, but it is still incapable of reliable diagnostic malignancy in many cases without a tissue diagnosis. Once a malignant lesion is diagnosed, there is still major controversy regarding optimal management in terms of the type and timing of adjuvant therapy and reconstructive options. Our target audience is abroad and include neurosurgeons, neurologists, and hand surgeons in orthopedic and plastic surgery, surgical oncologists, radiation therapists, psychiatrists, physical and occupational therapists, and even vascular and general surgeons who often collaborate and provide operative exposure for us. I wish to thank to all panelists today for their expertise and eloquence, and particularly to the ENS and Mrs. Anna Reck for their support and of this endeavor. Most importantly, we wish to thank to all our patients for their trust and confidence that we are constantly striving to improve our care for their neurological disorders. Special thanks goes to Christian Heinen for organizing this webinar and for creating this outstanding program, inviting all these distinguished faculties. And I will leave the floor now to Christian to start the webinar officially.
So, dear Lucas, thank you very much. Dear Anna, thank you very much for all your support. And of course, dear panelists, thank you for joining this group. And dear audience, thank you for joining our webinar. And I hope that we will, somehow fulfill the expectations that are that we raised with this program. So when dealing with peripheral nerve tumors, as Lucas already pointed out, we deal with a huge variety of histological entities, and each of them requires an adequate treatment. And it's not all black and it's not all white. And treatment differs in a very, very large way. And of course, perspectives differ in a very, very large manner. So the idea of today's webinar was to have as many perspectives as possible. So you see, this is first far beyond neurosurgery. We have plastic surgeons, we have sarcoma surgeons, we have radiologists, we have neurosurgeons, of course, and we go all over the globe. So we have a lot of perspectives in this today's webinar, and I'm very happy that we can start things. And I really hope, and I guess, that we will have very nice and fruitful discussions on the topics that we address. And I would like to invite everybody, as usual, to raise questions, to comment, to give their contribution. So I think we are ready to start. And as always, we start with the basics and with a general overview. And I'm very happy that Crescenzo is in the group today, and he will have the kickoff. And we hope that this kickoff will be as successful as the team of tonight's partita. So Crescenzo, please.
Okay. So, can you see my screen?
Yes.
Okay. Thank you very much, Christian, for the nice introduction. And yes, finger crossed for tonight. Thank you very much to Lucas Rasulic and for ENS staff for organize again another sections webinar. Today is the 5th, so it's a very nice goal that we reached. Well, when dealing about peripheral nerve tumors, it's important to say that, as you can see from this brief historical resume, inspired to this nice paper, peripheral nerve tumors has kind of a long history and the long origins. Anyway, it was only in the 20th century that the actual approach of dealing with peripheral nerve tumors were totally accepted and promoted. So before we are facing with the clinical features of peripheral nerve tumors, I think it's important that we are make a recap about the what we are facing with. As we all know, peripheral nerve tumors can be divided into big categories: the benign lesions, which are an heterogeneous lesions group, including about the majority of PNNTs. They can occur spontaneously or in multiple locations. And of course, there is the second categories, the malignant ones, which are actually aggressive soft tissue sarcomas, which usually arise from cell of peripheral nerve sheath. And since 2002, they are grouped into the acronymus MPNST to group all these pathological entities. The question is now how to deal with a patient with peripheral nerve tumors and how to do the best clinical examination. The typical presentation of PNTs ranges from asymptomatic mass growth or to unspecific signs and symptoms due to mass effects, for example, signs that involve surrounding tissues or direct nerve invasions. Indeed, the diagnosis is histological, but there are some critical criteria which help us or gives us a clue to direct to the diagnosis of a benign or malignant lesions. It's important to point out then, even if that usually benign peripheral nerve tumors are asymptomatic, the clinical assessment of the patients depend anyway from the tumor location and from the patient's profile. The most typical presenting symptom of a peripheral nerve tumors is pain, but it's also the most crucial symptom because it can direct us towards an idea of the diagnosis. For example, pain at rest is rare in the benign tumors, but it's almost always present in malignant tumor. In the same way, nocturnal pain or rapid intensified pain may argue against a diagnosis of benign peripheral nerve tumors, so directing us to malignancies. The differences between pressure-induced pain, which is usually occurring in both groups, and rest pain, which is usually typical for a malignant tumor, suggests that pain mechanism in tumor can be a different mechanism of actions. As we say, usually peripheral nerve tumors present only as a lump or with like an incidental finding in a clinical or radiological examination. It's important to remember that, of course, a rapid growth or a sudden enlargement of quiescent lesion can, together with pain due to compression, can be, of course, the first indicator of transformation in neurofibromatosis patients, and also the change of consistencies on subcutaneous hemorrhage can also be an indicator of malignancy. Tinosyne is a very important weapon in the equipment of examinator. It's the easiest and easiest reproducible neurological test. It's easy to perform, and it can be performed in every part of the body, giving us a important indication of the behavior of the tumors. Of course, neurological deficits are the most important indicators regarding the clinical assessment of a patient. A significant nerve palsy is, of course, the best indicator for malignancy. Anyway, it's not. It's important to remember that any sensory alterations or autonomic dysfunctions, or even a limb ischemia, can be found also in any type of peripheral nerve tumors. Usually, anyway, sensory deficits are present themselves early, while motor symptoms come kind of late and are like direct point out towards malignancies. So a careful and complete neurological examinations when dealing with a patient with a nerve tumor should always include the measurement of the size of the tumor to check out the location and the relation to near structures. It's to remember that that peripheral nerve tumors always move and direct perpendicularly to the major direction of the limb and never parallel to it. Then it's important to look out at the margins and consistency of the tumor and perform the auscultation. Last but not least, it's always important to check out for neurofibromatosis characteristic. In this regard, neurofibromatosis it's very important. It's a very critical autosomal disorder for the diagnosis of peripheral nerve tumor. As we know, there are three groups of pathologies. The type NF1, it's the typical, the most famous neurofibromatosis disorder, characterized of the growth of multiple neurofibromas, compresses nerves and tissues, and high risk of growth from MPNSTs. Usually the prevalence is from 2 to 5% in patients with NF1, if compared with the 0.001% with healthy population. Type 2 neurofibromatosis is characterized by multiple schwannomas involving all nerves of the body. Very typical for this type are like acoustical schwannomas, usually leading to hearing loss. It's important to say that NF2 schwannomas are usually, if ever, benign, and they never undergo to malignancy. But patients with type 2 neurofibromatosis are usually the, let's say, high pool of patients who undergo to schwannoma surgery. And then the third type, also called schwannomatosis, it includes the proliferation of multiple schwannomas, usually causing chronic severe pain and neurological complication. But curiously, this kind of pathology never gives acoustic schwannoma. In this picture, I just wanted to highlight the macroscopically difference between schwannomas on the left and neurofibromas on the right, and also the actual surgical technique that will be extensively discussed in the next presentation. And in these other slides, I just wanted to highlight that schwannomatosis is not like side B neurofibromatosis, but anyway, also a dramatic pathology. In conclusion, of course, it's important also to give an outlook to malignant peripheral nerve tumors. These are typically arise from transformations of pre-existing neurofibromas, but can also be sporadic or induced by radiation. They list usually from 3 to 10% of all soft tissue sarcomas, and their overall incidence is 1.46 per million of individuals per year. They most occur in proximal extremities, then trunk, then head and neck. And usually the most involved nerve are the sciatic nerve, the spinal roots, the brachial plexus, and so on. Even if solitary, it's important to remember that malignant tumor can also give kind of frequently long-term metastasis. As I already said, there is a direct connection between NF1 and MP and ST. Usually patients with NF1 at a much higher risk from developing malignancy with a high cumulative lifetime risk. Moreover, malignancy arises approximately 1 decade early in patients with NF1, with a peak between age 20 and 30 years. It's very important also to remember that neurofibromatosis 1 associated malignant peripheral nerve tumors account at least 20 to 50% of all malignant peripheral nerve tumors. Thank you very much for your attention. Now I leave the floor to the other colleagues.
Christian,
Do you want to continue? No.
No, I'm ready.
No, I mean,
you continue.
Okay. So, Crescenzo, thank you very much for this great overview of because I mean we will now see very, very high quality assessment, imaging assessment, but as Crescenzo pointed out, the clinical features and the clinical assessment still is nothing that can be replaced by any kind of machine or anything, because in the end it's the it's the brain of the doctor putting together all information and moving on with the next level, which is then of course imaging or electrodiagnostics. So the next.
And of course, sorry, Kristen, of course, there are a lot of more information about that. I just try to make a summary, of course, all of different kind of peripheral nerve tumors and different histological diagnoses, they are very difficult to group in just one categories.
It's impossible, especially not in a certain period of time. I mean, if we
definitely
could 3 webinars, maybe lasting 5 hours, we could cover a lot of the pathologies, but this was explicitly, as you did it perfectly, meant to be the essence of what is the most frequent, the most important, and what everybody should know when treating patients with peripheral nerve tumors. So thank you very much, Crescenzo. We thought to have a discussion of the first part, which is the introduction by Crescenzo and imaging. After now is the ultrasound, then there will be the MR, and then we have the first discussion round. So I'm really happy to have Maria now talking about neurosonography in peripheral nerve tumors. She is an absolute expert in this field. And well, we've been somehow building up ultrasound when we were working together, but the way she pushed forward the tumor topic is really incredible, and I'm really happy that Maria is with us. So please.
Thank you, Christian, for the introduction. Thank you, Lucas, for the invitation. So, as Christian already mentioned, we started together with neurosonography, and talking about ultrasound, we want to get the best resolution out of the peripheral nerves. So what we are actually using is high frequency. So I want to get the perfect picture, and on the right side you see a peripheral nerve intraoperative, you see the fascicles, And this is how a healthy nerve should look. But using high frequencies, you get a less or very low tissue penetration. And this, when we started, was actually the reason why we did it intraoperatively. So we decided to do an external neurolysis and then to use the transducer and take a look into the nerve. So this is how it started, especially in traumatic nerve lesions. Later on, we thought, well, why are we not doing it on peripheral nerve tumors? And we had some questions at the beginning. We wanted to just get new morphological characteristics of peripheral nerve tumors. We wanted to know how the tumor mass is looking like. We wanted to know what's about the fascicles and how's the perfusion, and also at the end, is it meaningful? Is it comparable to MRI or not? So those were the first questions. And then in 2015, we just published our first work dealing with intraoperative high resolution ultrasound using also contrast enhancement ultrasound. Just a few slides. This is how it looks like. We have a peripheral nerve. On the left side, you see a sterile gel cushion. The nerve is neuralized, embedded in it, and the transducer is also sterile wrapped. And on the right side, again, you have a complete nerve surrounded, and you see just the fascicles again. This was our study group, only 13 patients, but on the right side, you see all the different entities. So we also had tumor-like lesion, like the Lewis-Sumner syndrome, the first patient. We had a lymphoma, we had malignant peripheral nerve sheaths, tumors. We had also really rare malignant or chronic benign nerve tumors like perineurioma, amyloidoma, and fibrous tumor. This was our study group, and we just did an MRI on the whole patients, then decided to go for surgery and did the intraoperative ultrasound. And then the first time we just created 3 groups. And this is also the main question. The main thing we noticed is group A and B, where the tumor mass itself is like enlarged fascicles. So you have huge hypoechoic fascicles, really thickened. And group C, consisting of NPNSTs, but also schwannomas, the tumor mass is just a hypoechoic solid mass, and you don't see any fascicles. So the first thing is the fascicle structure preserved or not? And then you already can decide in which group you're dealing with the tumors. On the left side, you see a perineurioma. You see in red a huge fascicle, but you see that the structure is preserved. And on the right side, you see an ancient schwannoma consisting of multiple cystic formations. And it looks like really very, very difficult to distinguish where are the fascicles and not in there. This is an MPNST, and this is probably the second take-home message, because one of the main questions was, are we able to distinguish between benign and malignant? And we are not. So ultrasound alone won't give you some information, but it won't help you in defining what to do or not. So here is an MPNST of the sciatic nerve. Again, you see a huge tumor mass with cystic formation. You see hypoechoic, but also hyperechoic areas of the nerve. But then coming up to the preoperative ultrasound. So first of all, we just decided to collect our information, and then we took it to the preoperative setting. And all of you know those wonderful pictures, images of David Klein. And on the right side, you see an example for schwannoma. You see an hypoechoic, homogeneous, normal margin. You see the spindle-scape structure, and you see also cystic formation, and the not affected fascicles are, sorry for that, are just displaced. Coming up to perfusion, there you see in the superb microvascular imaging, you see a certain kind of perfusion. Coming up to the contrast enhancement, normally there is no bubbles coming in there. This is the right side, dealing with a schwannoma. Coming up to the neurofibromas or plexiform neurofibromas, it is more heterogeneous. You can have areas of hypoechoic, but going to isoechoic tumor parts. Again, you have the cystic formations and you have defined margins. This is an example of a perineural nerve. And again, in the color-coded Doppler mode, you have a kind of certain perfusion, but nothing really special about it. This is an example of a small MPNST of an ulnar nerve of a patient without neurofibromatosis. So he was really suffering a lot of pain and motoric deficits. He was operated on the capital tunnel on the Loge de Guillon and nothing happened. And nobody just took a look into the nerve. And then when we saw this, you see a mass, you also see a satellite metastasis, you have a hypoechoic dot, and you have again a cystic formation, and it was a completely inhomogeneous tumor mass. And here the clinic is very important, and this was just 3 centimeters. It was not above 5 centimeters, but it had really deterioration over years. Here is again another example of a sarcoma of the sciatic nerve. And you see you have some hypoechoic parts, you have again some cystic formation, you have a huge tumor mass, you don't see any fascicles at all, and it's just everything is possible in there. It is infiltrative and really inhomogeneous. Coming up to the contrast enhancement, those are microbubbles, and you see that those microbubbles stay in the vessels, and this is what you actually want to know what's about the perfusion doing in the tumor. And you have a quick wash in phase and a quick wash out. And on the right side, you see a B mode. So the problem on contrast enhancement, you have to use lower frequency transducers. So it's about a 12 transducer. And otherwise, those frequencies really destroy your microbubbles and you don't see them anymore. So you lose your resolution, but you were able to see really those bubble structures. And what we find out was that they had those malignant tumor masses have a positive perfusion pattern on contrast enhancement. So as take-home message, if you have a superficial local tumor mass, high-resolution ultrasound is really good also for monitoring those patients when you not want to operate them and you have an NF patient and you want to see him every 6 months or 12 months. It is really nice to control it as a normal tool. First question, is the fascicular structure preserved or not? Use it for perineuromas, amyloidomas. If you want to take a biopsy or you need to take a biopsy out of it, just use the ultrasound to plan your incision. And also, as you see on the bottom of it, if you don't know which fascicle you want to take out, just use the ultrasound and take an enlarged, thickened fascicle, always with motoric stimulation for sure, but I'm just telling you that the intraoperative ultrasound helps you probably in finding the right effect fascicle if you need it. And I just, as usual, bring you some papers which I really liked. So later on, we hear a talk out of Tübingen by Martin Schumann, and the group has a nice publication, kind of recent, dealing also with NF patients and telling you that ultrasound is a really good control tool to use it. On the bottom, you see a study out of Alexander Grimm, who is really doing nice publications, also from the Tübinger group of ultrasound, and he uses for neuropathies just to take control if the therapy is going on or not. And he's always using ultrasound at the weight and scan modality. So that's it. Thank you for your attention, and I'm open for questions.
Oh, thank you very much, Maria. Perfect and excellent. And I'm well, in this short period of presentations, you can only give, of course, an idea of what it's possible to use. And maybe we can discuss the both imaging modalities after the talk of Daniela. So I would like to invite Daniela from Buenos Aires, Daniela Binaghi from Buenos Aires, to give the presentation. And we will see beautiful images. And well, as Maria showed, the high quality of ultrasound, we will now see what MRN, what MR neurography can bring us to, and how the insight of a radiologist into peripheral nerve tumors is. So please, Daniela.
Thank you very much for the invitation, Lucas and Christian. Well, as Christian mentioned at the beginning, I will talk about peripheral nerve tumors, and I will show you the radiological perspective, which is a little bit different. Check. See. I have nothing to disclose regarding this presentation. And today we will go through the basic knowledge regarding MR neurography. I will show you how a normal peripheral nerve looks like. We will go through the visual clues that we need to look at when we need to identify different diagnoses. So what are we talking about when we talk about MR neurography? Well, the term was introduced in the early 1990s to describe the application of high-resolution sequences to see the peripheral nerve and surrounding soft tissues. And as I like to say, the MR neurography is a tailor-made examination that needs trained professionals and the use of high-field MR system, as well as dedicated radiofrequency coils. It is important to understand that the examination is tailor-made for the patient, and the protocol will depend on the region of interest as well as the pathology. And we will have anatomic sequences like T1, T2, and proton density, as well as T2 with fat suppression to identify signal changes. In case of tumor, the gadolinium injection is paramount. We really need to look at the patterns of enhancement because it can help us distinguish between different pathologies with similar non-contrast appearances. How does the peripheral nerve look like? Well, this is the posterior tibial nerve. You can see it has fascicular pattern and shows the signal intensity that is in T1 similar to the muscle, and in T2, and in this case proton density with a spare, is slightly hyperintense. And if we inject contrast media, it will not enhance. What do we need to look at when we're studying a tumoral patient or image? Well, we need to look at the enlargement, if it is diffuse or focal, if it only affects one nerve or more, and how does the fascicular pattern look like, as well as the signal intensity and the enhancement pattern. This is the most important in this case. We can also look at the diffusion tensor tractography, which will help us to see the 3D course of the nerve bundles and fibers. As you can see by convention, the tracts that run from head to feet will show blue color. The ones that run anterior to posterior or vice versa will show green color. And the tracts that run from to the sides will show red color. And if you don't remember which one is that the one that you are looking at, you just need to look at this. That will help you see if they run head to feet, anterior to posterior, or lateral. We can also see and need to see the fat planes around the nerves. Well, this is the first thing we radiologists learn first. all enlargement is not schwannoma or neurofibroma, because peripheral nerve enlargement is a distinctive radiological feature with multiple differential diagnoses. That we need to compare not only the enlargement, but other signs. In this case, we have, well, as you can see, there are many cases. They all have a clinical history behind. We will just take a look at the image now. This is a femoral nerve in the pelvis. This is a femoral nerve also the upper thigh. These all are sciatic nerves at the sciatic notch and the ischiofemoral space. And this is an ulnar nerve. We will not have enough time to go through all possible diagnoses, but I will show you some of them. In this case, we have fascicular enlargement with a high intensity signal. And you can see the fascicles are uptaking the gadolinium. This is a CIDP, a chronic inflammatory demyelinating polyneuropathy, which is really difficult to diagnose. And this is one of the patterns that might show. In this other case, we can see that the sciatic nerve is quite enlarged, and the epineurum, the external epineurum, is thickened and has dark color, is hypointense. And you can see the fascicles that are really enlarged as well and show high signal intensity. And of course, the fat pad around the nerve is obliterated by fibrotic tissue. This is an endometriosis and is easily seen on coronal. In this case, it's a coronal T1 spare, in which we can see the metahemoglobin that is hyperintense, spontaneously hyperintense. And you can see here the difference between pre and post-treatment control. In this other case, we can see the sciatic nerve at the femoral, ischiofemoral space. We can see it enlarged and with a loss of fascicular pattern. But if we take a look at the sagittal view and a more proximal axial view, we can see this huge mass that is a little bit heterogeneous and is surrounding the nerve, which is actually this tiny oval image here. This patient came with the normal CT that was taken the day before. So I asked the person that was accompanying the patient to show it to me. And look what we found. This is an atherotopic ossification that was comprising the nerve. So the enlargement was due to compression. In this other case, we have an ulnar nerve at the elbow. We can see the enlargement is diffused. And in the axial view, it's easier to see that the perineurium and the epineurium is thickened and has hyperintensity is dark. And this is a Hansen disease. So we went through all these diagnoses from an inflammatory auto-mediated pathology to compression and to infection. Now we can see schwannomas and neurofibromas, but I'm sorry to say that they share a common finding on MRN. We can see that they enter and exit their origin nerve, and on axial views, I don't have here a T1. I use a lot of proton density, and we can see all the fascicles that are on the side. And in this case, the DTT showed us show us a schwannoma. This is like a schwannoma, like a schwannoma looks like. I don't know if you understood that, but this is the way they look like. you can see the normal nerve coming, blue color, and then all these changes in colors because they are displaced. On this other hand, we have another patient. This is at the elbow, and this was thought to be a schwannoma. You can see some normal bundles here, fascicles here. So this is the tumor. But on DTT, you can see that the tumors are displaced, the fascicles are displaced, but the tumor does not react like the schwannoma does. So the bundles and tracts change color because they are infiltrated, but not too displaced. So the question is DTT the key to solve the problem? And the answer is no. You can see here this tumor at the peroneal nerve is eccentric and has continuity with the origin nerve. And on axial view, you can see all these tracts on the side, and the increased signal intensity of the tumor is an homogeneous on proton density spare and a little bit heterogeneous on T2. And the DTT showed the displacement of the tracts. This patient came with a prescription of conventional MRN. So we did not inject contrast media. But what could go wrong? It has all the findings that we find in a schwannoma. But it was not a schwannoma, it was an intraneural myopericytoma. So please always inject contrast media. In Argentina, if it is not prescribed, we cannot do it. So this is why we didn't have the diagnosis before the pathology. And in this other case, I got it right from the first time, but I want to show you anyway how it looks like. This is a perineurioma. And you can see in the sciatic nerve tracts normally here, the normal course here, and within the tumor, since the tracts are displaced, but not too much to the sides or up and down. So it looks like a neurofibroma because you can see all the infiltration, but the injection, the contrast enhancement changed the diagnosis, and it was right from the beginning. So DTT is another tool, and it is really important to inject contrast media. On the other side of the spectrum, we have the malignant peripheral nerve sheath tumors. And as it happens with clinical workout, we need to suspect malignancy. So we have all these findings that we need to look for. In this case, I can tell you already that it was a high malignant tumor at the brachial plexus, but it didn't have an ill-defined or invasive margins. It didn't have peritumoral edema. The diameter was large. It was 7 centimeters, and it was heterogeneous. They didn't take the DTI nor DTT sequence, so we don't have this result. But I personally look more at the angiogenesis signs, and I basically look at these tubular images that have a dark color in every sequence. Those are arterial vessels, and I also look for areas of necrosis. These findings are okay, but always look at the angiogenesis signs. So take-home tips. Why should we include MRN in the diagnostic workup? Well, MRN expands differential diagnostic possibilities from inflammatory conditions to really tumoral conditions, and determines the localization and extension of the injury, not only inside the peripheral nerve, but also in the perineal planes, and facilitates safe and complete resections. Also helps guiding target vascular biopsy. This is very important. There is always a clinical history behind every image. So my recommendation is to have a multidisciplinary approach. Thank you very much for your time.
Thank you very much, Daniela, for this outstanding and really, really beautiful images. I think this quality of images is really, really hard to find, at least from all the publications that I have been, in so far. Or so, thank you for joining us.
Thank you.
So we will now have the first discussion. And there were already some questions in the chat. And does anybody want to start? Other questions or comments?
Yeah, thank you, Daniela, for this fascinating talk, and also for the fascinating picture, as Christian already said. This is very, very exceptional also from that what we see here, and we are used in Germany from the Heidelberg group to have quite a good MR neurography. So maybe you can tell us a little bit about the secrets and the long way to get this kind of imaging. What is the secret behind it?
Well, as I said, to me, these are tailor-made examinations. So I check the patient first. I do the clinical exam, and I take the images. The technician is by my side, just in case the patient needs anything. But I am the one who decides which sequence and the plane that I need to take, and I see all the previous exams as well. So that's a secret. It's just having a closer look on the patient and the images.
So you haven't developed any special sequences or special combination of excitation and relaxation times and anything. So this is quite standard sequences, because the clarity is most impressive.
Well, actually, the images I showed were taken with the 1.5 Tesla scanner, and the sequences are there. I adapt them to the patient. I change a few parameters, but the secret is to look at the patient from every perspective and try to answer the questions through the image. If the image does not answer the question, then I call the neurologist or the surgeon or anyone who is at hand to explain it to me. And so they do as well. I think the image has to reflect what the patient has. And as they are dynamic, they will change over time. So it is super important to know the clinical evolution of every patient. So the key point is to really look at the patient, not only through a screen and from the image. We need to see more.
There's one more question from Tübingen. Martin, your boss is asking, Professor Tatajiba, can you replace PET examinations with these sophisticated MR studies to investigate MPNST? So you think PET is out?
No. I don't think that any other image technique has to be left on the side. There are moments in which we need the MRI, there are moments we need the ultrasound, and there are moments that we need the PET. So we need to choose between them when to use them. They will all give us information, and there is I won't left aside any of them.
Daniela, thank you for your beautiful images, and I just wanted to mention that I think I have the same opinion. It's all, and also what Christian just told us at the beginning, and I always use this image of a puzzle. So you have the clinical examination, you have the patient, his history, paresis or not, pain or not, and then the diagnosis is supported by our images. Yeah. And that's it. And we have all different modalities as perfusion and so on. And we need, it's just always giving you more information. And at the end, you have your puzzle.
Sí, absolutely agree.
So there's one more question from Professor Cordula Matis from Würzburg. How important is the orientation of the imaging? So
It's super important. In the plane, you mean? Well, most of the nerves should be examined on axial view, but axial to the nerve. So we can really see the fascicles, the interfascicular epineurum and external epineurum. There are some nerves that need other planes, but axial view has to be there. It's super important. And then the selection of the coil is super important as well, because we could start with a big coil, such as the one that we use for abdominal or pelvical imaging. And then the one that I use the most for superficial nerves are the microcoil sets, which are a set of very small coils. They have beautiful images. So we go from the huge coils to the very smallest ones.
Thank you. So there's one more question. I think this is one of the issues that was already addressed. And this is, I think, somehow a new feature. Well, not really new, but it's new to look for angiogenesis or somehow the vessel architecture in tumors. This is for both ultrasound and MRN, of course. And well, in the end, it's something that for us surgeons is very important too. Not only the intratumoral vascularity, but the surrounding ones. And Atom Onibe asked what contrast is used for high frequency ultrasound. Maybe Maria, you can answer this. Turn on the mic, please.
Sorry. It's called SonoView. It's from Bracco, it's called, and you have transducers like 12. And as I told you, you can't use a higher frequency because those are micro bubbles filled with gas, and you just destroy them if you use another frequency. But the main problem is that SonoView is normally used for liver tumors or breast cancer, but it's off-label for peripheral nerves, and this is the main problem out of it. So it's, as an individual treatment, you can use it, but our ethics committee is not really happy when we're using it.
Thank you. I would like to ask something to Peter Hohenberger. In imaging, from your, I know we will have your perspective in a very detailed way later on, I know, but since imaging is regarded, is there anything that you are specifically looking for in imaging?
Well, that is a nice fit to to the talk on the contrast agent and looking for the angiogenic zone. Typical, there are data out there coming from radiation oncologists about 8 to 10 years ago, analyzing in the resection specimen those angiogenic areas, which might sometimes involve the whole compartment of a muscle, even if the tumor is arising from a nerve. And they found tumor cells within this angiogenic compartment. They did that for their radiation oncology planning, but it's a clear sign of an aggressive tumor. We use the angiogenetic zone, not only in MPNST, but in all sarcomas, as that area which probably has the high grade area. The more the accumulation of contrast media, the more proliferation, the more blood supply, the higher is the cellularity. So that is, it's crucial. It's hard for me to understand that I would look for an off-label or on-label use in such a situation. You can say, okay, that's indication for doing the adequate biopsy, for example, not to do the biopsy from the low grade or from the benign remnant, but look for the aggressive part, because this makes the decision for treatment planning.
Thank you. That two more
Christian, see, there is on the chat, there is another question about DTT, if I do it in all peripheral nerve tumors. And the question is no. I select the patients as I select all the sequences. This is another sequence that I select. And it is important to remember that the DTT takes time to acquire. So if the patient is, well, you need to think that the patient is already in the scanner for at least 30 to 40 minutes. So this will take 10 to 15 more minutes. And if the patient moves within seconds of that sequence, it will not work. So I select the patient every time, and as well as I select the sequences. Thank you.
There are two more questions. One is from Dr. Gupta from India. How would you follow up an NF child? I think this is perfect for the talk of Martin Schumann. So I would ask Dr. Gupta to wait for the response after Martin talked. And then there's an anonymous spectator. I hope I didn't hurt the neurological feelings by not inviting somebody to talk about electrophysiology. So I apologize officially for this. But well, this is only my opinion, of course. But the assessment electrophysiology will give you information, of course, on how much a nerve is affected, but not by what. So I apologize once again, but that was the reason to well have it for the next time. Put it like that. So, but for assessment, for clinical assessment, and for assessment of the damage a tumor has done, I think EMG, ENG is crucial, because as you saw in both presentations, there are fascicle-wise lesions that do not include the whole nerve. And of course, a detailed EMG or an ENG will show you which muscles will be affected. Or if you think about the Kiel-Levin syndrome and you have fascicle-wise affection, or perineurioma not including all fascicles and so on, EMG will tell you exactly the way the tumor or the lesion affects the nerve. So yes, it is absolutely crucial, and I think it should be part of the workup when dealing with a patient with functional loss. So this is for the questions from the chat and from the participants. Are there more questions from the panelists or comments? Because we are quite well in time. although having a very nice discussion. Lucas, what do you think? You're the president.
Yes, I think the discussion was perfect. The presentation was outstanding, and if there is no question, we might continue with our program, if you agree, Christian. So far, so good. Excellent questions, excellent discussions, and we can continue in a further part of discussion, all of this part of important questions. But I will now continue with the program, and I will cordially invite Fernando Guedes from Brazil to give us his talk about biopsy or no biopsy. This is a very important question in surgery of peripheral nerve sheath tumors. We are now at the moment of session of treatment of benign lesions, benign peripheral nerve sheath tumor lesions. Fernando, your mic.
Yeah, I'm here.
Yes, and your camera.
Where is my? Okay.
Yes.
There I go.
Yeah.
So good afternoon, everyone. Thank you, Lucas, for this kind invitation. To my German brother, Christian Heine, thank you very much. So biopsy or not biopsy? This is a great subject, very difficult to talk about this, and I must emphasize that I will not be dogmatic. It's not going. There is no conflict of interest. So why biopsy a lump? So the first question we must address is the lump in a peripheral nerve? And if it is in a peripheral nerve, what we would like to know? We would like to know if the lump is malignant. This is the main problem. I will not enter in the discussion of many other reasons of enlargement of a nerve. Daniela has showed us. But from a perspective, a surgical perspective of a nerve surgeon, we want to know if the lump is malignant. Now, we saw the importance of the clinical examination before, and I fully agree that it's very important to see the patient, to examine the patient. So you must suspect if the lump is on a nerve by the anatomy, by the path, the pain goes, if the other associated findings, but you are never completely secure if the lesion is in the nerve. For that, you use imaging. So in this example, I will not stay here for long, but in this example, most of us would say, well, this is probably a benign tumor. The fascicles are on the periphery, the tumor is eccentric. As a matter of fact, this was a schwannoma. But as we saw, Daniela showed us very well, it's not 100% secure. But most of the time, if you put together the clinical history of the patient, and I will not talk much about this, we saw before, and some aspects of the imaging, you can suspect probably this is benign. The situation is completely different with a case like this. And at this time, at this juncture, I must tell you that maybe for one malignant tumor of the nerve, you have, let's say, 100 benign tumors. So malignant tumors are rare, malignant tumors of the nerve. If you have the possibility of PET scanning, this is important because as we saw, some spots to perform a biopsy, image-guided biopsy, it would be more easy if you have the information of this exam. The problem is that it's expensive and we don't have it in most parts of the planet, I should say. For me, at least, I cannot have this next door. It's pretty much difficult. And I also don't have Maria Pedro to help me with the ultrasound. So we rely on MRI basically. Now, you decided to make a biopsy. I don't know exactly what that lesion is. So I want to know before operate the patient, I need to have a sample of this lesion. Well, we have some different kinds of biopsies. Fine needle aspiration. Let's take a look of the accuracy of fine needle aspiration for schwannomas. So we can find in the literature that there are some problems with fine needle aspiration. Well, I have the possibility to make a fine needle aspiration that spot the precise area in my institution. Okay, but what we see, it's fine needle aspiration is not so good, so accurate. Let's see the quantity of material it is provided by fine needle aspiration. It's not perfect also. And the accuracy for malignant peripheral nerve sheath tumors. Maybe you agree, maybe you will not agree, I will not be dogmatic, but in our experience, patients that had fine needle aspiration for tumors, diagnosis sometimes was not correct. The other possibility is core needle biopsy, image guided. So here things are a little bit different. It is possible to arrive to a correct diagnosis in many cases. We used to do that in our department. The interventional radiologists, they go there and they can take a good piece of the lesion. By the way, this was a tumor compressing the sciatic nerve and was a sarcoma, and this patient was sent to surgical oncology to be treated, not for us, for them. And to diagnose malignant tumors by core needle biopsy, PET-CT guided, the results are good in the literature. We don't have experience with this technology. But there are some complications. New onset motor deficits, post-operative neurological deficits when you have to operate the patient, and worsening of pain. But this is another problem with biopsies of tumors. You can biopsy an area, for instance, spot number 1 would be a neurofibroma. And if you biopsy spot number 3, it would be a highly aggressive tumor. So you must bear in mind that if you don't have a good quantity of tissue in your biopsy, you may be in the wrong way. Another question is the grading of malignant tumors. And we now discuss low grade. It was said before about low grade and high grade sarcomas, neurosarcomas, but this is not new. You see in 1931, these colleagues from New York, they already discussed about low grade and high grade tumors. And I want you to look at with me at number 8. The tumor grade is important to estimate prognosis. Look at that, 1931. So they would call attention about low grade and high grade in the so-called neurogenic sarcomas. This is another problem, and it's not only academic because it can have surgical implications. Some colleagues say that in low grade malignant tumors or atypical neurofibromas, they may be the same thing. It's under discussion. Probably you don't need to have negative margins. So negative margins would be a little benefit for low-grade malignant tumors. I don't have a position about this, but I'm just call your attention that this is another area of discussion. We have published a small series of tumors in children. And this is, for an example, this young girl had fine needle biopsies elsewhere, and it was a schwannoma. They didn't know it was a schwannoma. It was a schwannoma. Let's observe the patient. Then the tumors was growing and decided to make incisional biopsies. There you see the scar of the incisional biopsy. This was the MRI. Okay, we operate the child. It was a very malignant peripheral nerve tumor from a branch of the femoral nerve. So there was a problem with the conduction of this case from the beginning. and the kind of biopsy elsewhere they decided to do. When should we biopsy? We perform a biopsy. This is our view, not dogmatic. I may be wrong, but if the clinical features suggest malignancy, imaging features suggest malignancy, in some cases, in many cases, with these highly suggestive features of malignancy, we think you should biopsy. Now, what technique or which technique should be preferred? There are several guidelines indications indicating the kind of a core needle biopsy imaging guided biopsy for soft tissue lesions. We will have a colleague from the sarcoma surgery, and he will talk with us. But what we found in the literature is that core needle biopsy would be important for soft tissue lesions. We tried to find specific recommendations for peripheral nerve tumors, and we found out these UK guidelines. And look at that. They advocate excision biopsy for suspicion lesions on MRI. And they stress this: you need an expert pathologist to evaluate the lesion. I saw him saying no. Okay, we will hear later. This is a recent paper, and they say here also that maybe would be more important to take the tumor and not to rely on biopsies. This is not our position. I told you before. We agree that these patients should be biopsied, before you undertake the surgical procedure, because it will change. We think that it will change the way you will treat this patient. You will change the way you treat this patient. In conclusion, we try to be sure that the lump is a peripheral nerve tumor. We do not biopsy what is probably a benign peripheral nerve tumor, but we do biopsy tumors that are highly suggestive of a malignant or indeterminate diagnosis. And we don't usually biopsy asymptomatic tumors. Open biopsy or MRI or CT guided core needle, when available, should be preferred. We don't have the opportunity to make a PET scan guided biopsy, but we think you should biopsy. If the tumor is malignant, the way you will treat these patients, in our view, is different. It's different because sometimes you have to make a resection of the nerve and everything, and of course, create a neurological death. And your best friend is your neuropathologist that will help you, and also the people from MRI and from imaging. I forgot to put here, but I apologize for that. I would like to invite all of you for this course, if it will be possible because of the pandemics, in November in Rio de Janeiro. Vielen Dank, and thank you very much.
Thank you, Fernando. Excellent presentation, like usual. Now we are going to the next presentation, which is related to surgical techniques in benign peripheral nerve sheath tumors, given by Christian Heinen.
So, thank you very much for having me, Lucas. And of course, I want to once again thank Anna to have all this fantastic organization and all the panelists. So now that we have been diagnosing a mass and we have been biopsying a mass, what will we do? What's next? So the next is that we need to decide that we will operate. There was 2 years ago, there was a very nice paper by Robert Spinner from Rochester, and he took a motto that was used for the Olympics in 1988 with a very horrible song. And you see, the fashion has changed, but the goal is the same. So go for gold. And I will try to show you in the next slides the basic principle of, in this case, a schwannoma enucleation without functional loss, because I think this is something we all agree must be the goal. when dealing with benign tumors. So this presentation is only with concerning benign tumors. I will show you two patients. They had the same pathology, but different outcomes and different ways of treatment. So the first patient was a distinct lady with a painful mass at elbow level and a strong Hoffmann-Tinel sign and median nerve territory without functional loss. The functional loss did not appear, so it was a plain resection, and it was confirmed to be a schwannoma grade 1. So you can see here these imaging. I apologize to Daniela for the quality, but you know, we need to work with something, and this is what we get. I did ultrasound on her, but it's not included in here. So this is the median nerve with the typical appearance of a schwannoma. And the goal was to remove it. And this is what was already addressed and what in the chat Carlos from Mexico pointed out. This is crucial to have monitoring conditions. So at least, or what I use most of all is the, as Maria already pointed out, the motor stimulation. So I will show you a video. My beautiful daughter Elisa edited for me because she thought it was too long. And I will show you step by step how to approach. So this is the median nerve exposed. You have the proximal and the distal healthy part of the nerve. You can see this fascicle running around. You can see the epineurial or paraneurial stimulation. And now we need to find the plane where to dissect. So this is not my Parkinson. This is just a speed up video. And this is not epineurium. This is the paraneurium. So I will open it up. And as you can see, I do it in a longitudinal way. Why? Of course, because if you cut transverse, you will have a higher risk to damage the fascicles. And in this way, you can easily find the planes of dissection and not harm the intact fascicles. So we are still in the epineurium because this tumor, the schwannoma, is, as Crescenzo pointed out very nicely, is intraneural. So it's within the epineurium. So there are lots of discussions about planes and tumor and capsules and pseudocapsules and so on. So what I'm doing right now, what you see now, is the, again, stimulation. This time I'm on the epineurium, and you see that I just opened the paraneurium, and I will leave it. So after surgery, when it's done, it will go back around the nerve. I don't remove it. I just push it to the side. So next step is to open up the epineurium. You can see again a fascicle appearing that has been displaced by the tumor mass, but it's within epineurium. So I will, in the next step, I will open this up. And for that, we need to have the stimulation to be sure that we will not harm any fascicle. There are groups that use, and I think it's, well, I think it's useful to use, that use sensitive evoked potentials to also monitor the sensory function of the nerve. So I now decided where the plane of opening the epineurium is. I want to preserve this particular fascicle. So I open the epineurium close to it. And with this beautiful scissors, this really, really, really beautiful scissors, you can have a very precise dissection, because the tip is almost of micro scissors, but the strength is of a normal scissors. So I really, really like these scissors. And now you can see that I cut the epineurium. So you can see here the tumor surface, and here, now covered, here you can see the epineurium. So this is, the scissors are between epineurium and the outer part, the capsule of the tumor. And this is the layer exactly where I want to get to. So this is dissecting out the tumor out of the nerve and preserving the interfascicular epineurium. As you can see here, the tumor capsule is opened, this one. I think I hope this is visible. And so what I want to do now is to have an exposure of in a longitudinal way, again, not transverse, but longitudinal. And now I use the sector because you can see it's very slim. It's very not hampering the fascicles. If it would put in something, you know, with broader. So I go around the tumor capsule, so the outer aspect of the tumor, and remove step by step the tumor from the fascicles that run here in the interfascicular epineurium. So once again, it's speed up. You can use perfectly irrigation and to see better the colors change. And now I'm looking for the feeding fascicle in and out. So this is what will appear here. Exactly. So this will be coagulated and cut. And my opinion is that the best way to prevent a recurrent schwannoma is to do the resection, the cutting of the tumor-bearing fascicle as proximal or as far away from the tumor as possible. It's not about resecting capsules. We are not capsule surgeons. We are removing the schwannoma and leaving the nerve intact, because the capsule a lot of times can be confounded with the nerve, the interfascicular epineurium. So we cut out the nerve. So I think this is a very, 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 very important way. I will show you later on why this is important. And now I'm dissecting out the rest of the tumor. The same thing happens in the distal portion. So we will cut and coagulate the same tumor-bearing fascicle as we already did proximal. You can see there's no motor reaction. Even if I would have cut it up here, the reaction would still be here because Wallerian degeneration is not taking place within seconds. So you can see the nerve perfectly intact. Aside from the opening, we have the tumor out, and that's it. So this is what I mean. Of course, I showed the Sunday dinner family example, and not a horrible one that you don't have the planes and that it's very adherent and that you have fascicles running in and out and that you don't know it's a schwannoma or neurofibroma. This is a show-off video, of course, because I want to, it's always like this when I operate these tumors, as you know. Of course, it's not. So we have the different types of adherences and we have problems, and sometimes we are not sure if we sacrifice the fascicle, and the patients will tell us only after surgery. But the goal is to find the layers and to use them and to move within them. So security for patient will be as high as possible. The second patient was an NF1 patient. He had a suspected Baker cyst in the popliteal fossa, and he had just pain on, not at rest, but pain when touched, so atenal, basically. And the report of surgery described an R0 resection, but the patient had complete loss of function and neuropathic pain. So he was referred to us. These are the, once again, I'm sorry, Daniela, these are the images we got. So this is pre-op, sagittal view, fibular head. You can see, well, somehow you can see the intact fascicles pass by, and you see the tumor mass. And what do you see on the post-op? You can see incoming fascicles. Maybe here with some fantasy, you can see the outgoing ones, but there's something lacking in between. Same as for the axial view, contrast enhanced. And this was the intraoperative view. On the left side, you have the proximal part at the thigh, and this is just above the trifurcation of the nerve. So here would be the fibular head. So these are the two stumps. See, perfect R0 resection. congratulations. And we grafted it. And well, I think it's obvious what the goal of such surgeries is supposed to be. And I thank you very much for your attention.
Thank you, Christian. Excellent surgical technique and excellent presentation. Benign lesion out of not so easy and very challenging for treatment in order to preserve function, but we'll discuss on discussion. I would like to invite our next panelist, Nora Dengler, to give us a talk about outcome following surgery in benign peripheral nerve sheath tumors.
Thank you, Christian and Lucas. I'm very happy to be on board again. And I'm also very happy to talk with you or discuss with you possibilities of outcome in benign peripheral nerve tumor management. And I think the talks of Fernando and Christian were excellent introductions to clinical management of these tumors. However, I want to give you some practical ideas and maybe even advice how to counsel your patients and how to structure your recommendations. And let me start with some short reflections on outcome, how we consider outcome, how it is measured, and what factors may be influential for outcomes in patients with benign peripheral nerve sheath tumors. And first of all, I want to talk to you about quality of life, and I think this is the aim and goal of any of our patients, to achieve good quality of life. And nowadays, we do have very nice tools to measure quality of life and to structure quality of life. And I think one of the most frequent views on quality of life is that there are different dimensions that affect life quality. And this is mobility, self-care, ability to manage daily living, as well as pain or discomfort of bodily needs, fear, as well as an individual perception of health. And of course, the classic outcome is the function. And in peripheral nerve sheath tumors, this is motor function as well as sensory function and pain that has to be considered. Moreover, the freedom of recurrence of tumor also influences the quality of outcome. Which are the factors that we cannot influence, but we have to consider? This is, of course, the patient's baseline. And the baseline of the patient's function and quality of life may be influenced by tumor location, as well as the primary disease, which was already part of the discussion, which may be genetics or the genetic background. And then there is one factor that we can influence, especially as a surgeon, and this is the therapies. There are two general ways to go. The one is watch and wait, and the other one is intervention. And I think most of the panelists would go for microsurgical resection with intraoperative neuromonitoring. This is what Christian nicely showed, and what extent intraoperative neuromonitoring might differ between centers. So this is what I want to go with you. Want to go with you through the next 10 minutes. What can you expect as a treating physician? And what can the patient expect from an intervention? And is that known? What can the patient expect if he prefers watch and wait? So what are the options when the patient presents to you? What can you expect as a treating physician in terms of tumor location? And I refer to some large US American series. There's one on the right-hand side. This is the Louisiana series, one of the largest US American series. And you can see here that most of the tumor are located within the brachial plexus lesion, around 1/3. Another frequent location is upper as well as lower extremity. And if you look on the left-hand side, you can see the Miami series, where most of the tumors are located in the lower extremity. What factors might influence these differences? Possibly one is the genetic background. However, both of these groups were influenced by a high amount of patients with NF1. But the other one may also be the local referral policy. So when do the patients present? Which are the local referral options that the possibly general physicians to have? So this might be another factor. However, you should be prepared for a lot of patients with tumors in the brachial plexus regions, as well as in the lower extremity. What can you expect as a treating physician in terms of how the patient does present? And on the left-hand side, the upper part of the slide, you see some data from our peripheral nerve tumor registry. This is the preliminary retrospective study arm, and you can see here that most people do present with sensory deficits, more than 40%, and with a positive T-nil sign. Pain at rest is present in a little more than 20%. Motor deficits are only present in a little less than 20%. If you look on the right-hand side, you can see the Mumbai series, a very large series from India, where you can see here that there are a lot of people involved with pain, and they even differentiated pain between mild, moderate, and severe. And more than 80% have moderate to severe pain, and only a few have mild pain. So the number of patients presenting with pain, severe pain, is higher in that cohort. However, the number of patients with paresthesia and motor weakness are similar to our students. This is also true for the series here on the left lower side of the slide. You can see that weakness is present in around 16%. They differentiate between paresthesias and numbness in around 20%, and pain is present in a large amount of patients, with around 80% of patients that present with pain. Again, this might be influenced, especially the high number of patients that present with pain, due to a high number of patients with NF1 involved. Our registry data only comprises of 12% of NF1 patients, similar to the Mumbai series. So what is the patient's quality of life at presentation? We do have some very nice standardized questionnaires, and one is the EQ5D5L, which has a very nice evaluation for every country. And the methodology comprises of 5 different dimensions where quality of life is measured. One is mobility, ability for self-care, ability for daily living, pain, as well as anxiety. And there is another factor involved, and this is the individual health score, which is measured by a visual analog scale. And 1 to 5 points are taken for every dimension. 1 point is there are no problems. 5 points are they are extreme to severe problems. In our retrospective register arm, we were able to let 36 patients complete the questionnaire before and after the intervention at Charité Berlin. And our cohort comprises mainly of sporadic schwannoma patients. Some neurofibroma, myxoma, carcinoma, and fibro low-grade sarcoma are involved. And again, we only do have a small amount of NF patients in that cohort. So what is the patient's quality of life at presentation? On the left-hand side in the box plot, you can see 100 is the best quality of life ever, best individual expression of health. And in our cohort, the median was with 65, the mean was 60. If this is compared to the general German population, where around 80 is the value on the scale, this is significantly lower. So even patients with only sporadic benign peripheral nerve sheath tumors do have a significant lower individual expression of expression of health. On the right-hand side, you can see the 5 dimensions. This is German, so I'm sorry, I'll give you a short link. This is mobility, this is ability for self-care. These are the daily living activities. This is pain as well as discomfort, and this is fear and anxiety. And especially regarding this part here, referring to pain as well as the discomfort of bodily function, you see that there are large to extreme problems in around 40% of patients. Some problems are reported in more than 60% of patients. So a lot of patients do have some limitations in their life quality. So what can the patient now expect from intervention? And I think this is a very, very crucial point, that we can counsel our patients and that we can set the rate for the expectation of what he can expect when we intervene. And this is a recent publication from the US, American, and Canadian group. And this is multi-centric data of a lot of experienced neurosurgeons. You can see Linda Yang, Eric Vega, Robert Spinner, Regit Mida, so very, very experienced people. And you can see here, they dichotomized into the total of deficits as well as in permanent deficits. And you can see here that some deficit is present after surgery in about 27% of patients. It is permanent in only 12%. And if you divide that into pain, sensor deficit, and motor deficit, you can see that the most often you have paresthesias after surgery directly. These are 21%, but 9% are permanent. Neuropathic pain is present in 8% of patients after surgery, but only permanent in 4%. And presence of motor deficit after surgery was examined in 7% of patients, but it was permanent in 3%. They also had high amount of patients with NF1, NF2, and NF3, more than 1/3. And this may also have an influence on the results. So what can you expect in our series? Again, it represents a series with only a low number of NF patients and more sporadic schwannoma. Here is the preoperative state. We have pain at rest in more than 50%. Motor deficits in the sporadic cohort was present in 28% of patients, and sensory deficits were present in 50%. How did that resolve after surgery? We were able to show that pain at rest did improve significantly from around 53 to 28. This was significant. Pain at stress was also lower after surgery, but this did not gain statistical significance. Motor deficits improved in our cohort, but sensory deficits somewhat increased. How did life quality change after surgery in our series? And if we go to the part which was mainly influenced, the part of bodily discomfort and pain, you can see very nicely that the number of patients that report no to only small or no problems increased a lot. And the number of patients with huge problems, these were around 30, improved to 10%, as well as with extreme problems from 8 to 3%. So surgery was able to increase the amount of patients that report not such big problems regarding the quality of life. This was also true for the part anxiety and depression. The people who reported no problems in that field increased from 50 to 75. This is another way to show you. We go from 0 to 5. 5 is a lot of problems and extreme problems, and 0 is no problems. These were, again, the different dimensions: mobility, ability for self-care, daily living, pain, as well as anxiety and fear. You can see very nicely that these parts, pain and fear and anxiety, did improve the most. However, standard deviation was high, so this did not reach statistical significance. So after giving you an idea on what the patient can expect after surgery, I also want to talk to you about the possibilities that the patient has to expect if watch and wait is preferred. If we go into the literature, there's not really a good amount of data on that. There's only one series. This is the Mumbai series with 442 cases. You can see here in the flow chart that there are 75 patients that were only followed up because they were clinically asymptomatic. But in that publication, they did not go into detail if they ever turned symptomatic. There was a follow-up of 4.2 years, but we did not receive any detailed data on that. And if you look here in the lower parts of the discussion, you can see that in the symptomatic group, there's no role of conservative treatment. So let me sum up the part watch and wait. What is the role of watch and wait? We don't have any specific data in the literature. However, we cannot expect a relief of symptoms. So if we decide for surgery or not, we have to, of course, consider the symptoms of the patients. If we don't perform any surgery, even not a biopsy, we don't have any histopathological results. And if we go back to the data, how do the patients present before surgery, we have to assume that they suffer from a reduced quality of life. So let me sum up what outcome in treatment of benign peripheral nerve sheath tumors is like regarding function as well as life quality. Primary symptoms that the patients do present with are pain and sensory deficits. The genetics may influence the patient's status at presentation. Before the intervention, the main impact on life quality are in the dimensions of pain and anxiety. The outcome of surgery in terms of function, what can the patient expect? He can expect a significant improvement of pain in most of the patients. In some patients, we also found an improvement of the motor deficit. However, and this is important when we counsel our patients, we have to talk to them about the risk of new deficits. And in the large US American and Canadian series of the very, very experienced neurosurgeons, they reported 27% of transient deficits, as well as 12% of permanent deficits. And here we have to report 3% of motor deficit. However, the outcome of surgery in terms of quality of life showed improvement in our data. And if we counsel watch and wait, we have to consider that we don't have any robust data what is going to happen to our patients when we do watch and wait. And we have to be careful because we don't have a histopathological diagnosis if we don't perform surgery. Thank you very much.
Thank you, Nora. In order to continue with our program and to summarize discussion for all surgical treatments and outcome of benign and malignant peripheral nerve sheath tumor lesion, I would invite Christian to continue the program, and then we will have a discussion.
So thank you very much for this. What everybody should know, Nora is not where she's appearing to be. So thank you for joining us even in your holidays and for this excellent presentation. So we will now bridge the gap as already some of the panelists opened. We bridge the gap to the malignant tumors and have and somehow like in between talk. And I'm very happy that the Tübingen group by Marco Sotajiba and Martin Schumann suggested and joined us. So welcome once again, Martin. So, and as already raised before as a question, I would now invite Martin Schumann from Tübingen to give his presentation on the treatment of kids with neurofibromatosis. And of course, this will be including benign and malignant tumors. Martin, please.
Christian, thank you very much. Also, Dr. Rakusic, for the invitation and the opportunity to present our part of our Tübingen experience. Since we are also an NF1 center, NF center, not only NF1, it was kind of the opportunity to present the pediatric population in NF1, which is a special population which we feel sometimes could be served better by if the knowledge about what to expect from surgery would be more out in the community of parents and pediatricians. We analyzed recently our pediatric nerve tumor cohort from 2006 to 2017 and looked into 772 peripheral nerve tumors, which were resected in 414 patients. And there were, of course, phacomatosis, NF1, 2, and schwannomatosis, and sporadic tumors. 82 pediatric patients and 332 adults were analyzed in that series. And as you can see, in 172 adult phakomatosis patients, we removed 434 tumors or tumor procedures, which sometimes in these more complex tumors, plexiform neurofibromas contain more than just one tumor. And you see phakomatosis goes along with several surgeries or several procedures at the same time in these patients, because it is a tumor burden disease and it is not just a single tumor. And you can see in the adult series of 160 adult patients, we had 170 sporadic tumor procedures. So the majority of adult patients which have sporadic tumors have one symptomatic tumor, which maybe might occur, but the majority of the patient is done with a single procedure. We recently reported, as it was mentioned before already by Maria Pedro, our adult experience in only sporadic schwannomas, which was published just a few weeks ago. And I'm going to report today on the pediatric experience. So all pediatric cases in 82 children and adolescents or teens. The characteristics of that population or cohort is 82 children. We had 168 surgical intervention and removed 206 tumor manifestations in these closely 170 intervention. And you already can guess from the balance between children and number of interventions that there is a lot of NF in there. We are a little slight preponderance of females in that cohort here. And as you can see there in these children, a sporadic tumor is something extremely rare. We just had 9 patients corresponding to 11%, which had a sporadic non-phakomatosis associated tumor. So this, and that is well known that children normally have not sporadic tumors in a higher frequency. This is a disease of the adult population. And as you can see, almost 77% were NF1. So NF1 children have a higher tumor load or symptomatic tumor load, tumors wanting surgery than NF2. And schwannomatosis in children, again, is very rare. It's also the peak incidence of for schwannomas and schwannomatosis is above 30 years normally. So 90% are phakomatosis associated in children if you have these tumors, and 86% of those 90% are NF1. So the majority of these patients had only one site intervention. That means we addressed only one tumor or tumor complex at surgery. This was 88%. In some patients, we did 2 different sites in different locations. That means 20 tumor manifestation. And this went up to 3 sites, and even 3 patients had 5 sites addressed at the same time. In about 77% of the cases, we had a complete tumor resection, and the indications for surgical intervention is pretty easy. So we have the majority significant tumor growth, which always leads to either symptoms or the fear that we are going into a phase of an atypical tumor, which might progress to a MPNST. We have local effects in some cases, and in 4 teen occasions, we really suspected a malignant tumor according to the radiological characteristics, not due to the significant tumor growth, but to the according to the radiological characteristics, as we heard already. So 80% is pain and significant growth, most of the time these children have some kind of symptoms or are disturbed by the lump. As I told you, a lot of neurofibromas because we have a lot of NF1 patients, so 80% are neurofibromas, and about half of them are where a tumor was addressed in the peripheral nerve, so associated to a nerve which might have a long distance of the affected nerve, or the whole nerve is affected, but we were just addressing one lump, which was the problematic one. About 26% were plexiform neurofibromas infiltrating into tissue, into bone, into organs or whatsoever, which needed to be addressed. And there were also some cutaneous cases. And the next most common then was schwannomas. 12% in the series were schwannomas, and that are the other tumors. We only, fortunately, had 6 MPNSTs. So for the majority of cases, we were fast enough and cleared out the tumor before it became malignant. And ganglioneuromas, interestingly, 3 in children, more common in children than in adults. And less perineurioma, which are more often seen in adult patients than in children. Sporadic tumors, again, the sporadic were more schwannomas or other things. A neurofibroma, a sporadic neurofibroma is very rare in children, like in adults, where we have more schwannomas than neurofibromas. That's similar here. And also 2 sporadic MPNSTs, which were not associated to phacomatosis. I'm just showing you some examples of these PNF manifestations, which are non-neurosurgical tumors. This is a little newborn with this PNF, which you can see on the skin coloration and the lump under the skin. But this, for cosmetic reasons, we would not try to excise everything here above the facial nerve. This is an observational case. Things like this in the tongue, PNF of the tongue, you would not treat, and also these extensive things here in the skin with underlying tumors is something you have to watch. Manifestations typical in children with NF1 in the hand or in the foot. If you decide for treatment because of too many symptoms or too large feet, that is something for the plastic surgeon, nothing we would do on our own without the help of our friends from plastic surgery. This is a manifestation in the whole arm. This child has the whole median nerve transformed into a plexiform neurofibroma situation, and she had pain in there, and we actually did not see in that occasion an indication for treatment, because nowadays we have MEK inhibitors, and we can give these children a try with a MEK inhibitor than embarking on surgery. I'll show you a surgical case at a time when we did not have MEK inhibitors. And this again is a non-surgical case. You will never be able to address the whole problem. But in this child, we have already operated on at least 6 or 7 fast-growing tumors with PET uptake, like the one you see here in the thoracic aperture. So that was removed because this was PET positive and it was not yet malignant. So here you can only address specifically parts of the plexiform neurofibroma where malignancy is in the development. The localization in these pediatric series was pretty evenly distributed, cervical, thoracic, everything between 15 and 23%. So you basically find it all over the body, and there's not a special region which is predominant in the pediatric manifestation of mainly NF1 patients, as I told you. What was the functional status prior to surgery? We had the majority of all patients had no motor function problems. So it's 90% NF patients, and we have mostly no motor function problem. A few have up to severe, but the majority has no motor function. And the same thing is the sensory function. So there is no, for 90% of the case, and there's no real problem with sensation. The main problem is pain. You see, only less than 50% had no pain. And those who have pain have it mostly moderate and severe. So almost 50% of the patients have moderate to severe pain, a few mild pain. So pain is the main problem in these NF1 children. And what was the outcome after surgery? So we actually had only in 3 cases a minor motor paresis, a little weakness. From 5 out of 5, we went down to 4 out of 5 in 3 cases of 166 interventions and 206 tumors. and similar in sensory function. We had a little bit higher rate of a mild sensational deficit at the time of discharge. So that is all taken at discharge, because as we all know, the tumor comes mostly from sensible fibers. So that it's no wonder that we had 7 cases where we had some new deficits, even though if they were mildly, but also 2 patients improved from anesthesia to a major loss of sensation, or from major to moderate loss. So sensory function also is not a problem. You need to tell the patient that he might have some effect at the time of discharge at surgery. Pain, however, is a dramatic change. So we have a 2-fold increase from 43% to 81% pain-free. So it's a dramatic increase, and those who actually have severe pain, we have a reduction from 44 patients to 3 patients, that's 93% less, and moderate pain also goes down by 95%. So we will have a very good result on the pain problem in these patients. The overall combined outcome for motor, sensory, and pain taken all together at discharge is 75% of the patients are better, 23 are unchanged, and 2 worse. And at the end of follow-up, which was 3.3 years in this cohort, we still maintain the good, the better, and the unchanged basically is similar, but most of the patients really maintain their good improvement of surgery, taking all qualities together. In the end, I'm showing you some case examples. This is a solitary tumor in the perineal nerve in an 11-year-old NF1 girl, and she has now this increasing tumor, and you always ask yourself, why are these people coming so late with such a huge tumor? And we see in the PET already that it is strongly taking up contrast, glucose. So in the FDG PET, there the SUF max was 5 or 6, so clearly in the range where it could be a malignoma, but we had no actually sensory and motor deficits. And that is always something that talks in favor of a still benign lesion and of a NNUBP tumor. And that is the intraoperative approach, very similar to that what showed Christian to you. You do first the dissection around, and as Christian showed you, as he told you, a nice case where with the easy to dissect capsule, and in NF1 cases this can be the case, and you will see here different. So this is the tibial nerve, this is the sural nerve, which is already on a rubber band, and we are dissecting now the tibial nerve below, and the tumor comes from the perineal nerve. And now you have the usual, as Christian showed you, you try to dissect down level by level until you actually enter the last plane. Sometimes this plane between the capsule and the tumor is nicely, so we stimulate for the functional fascicles, and then select an area where we are sure that there is no function. You cut through the capsule inside the tumor of the tumor, and then there is a dissection which can be quite tedious, as you see here. It's not so always so easy, but nevertheless, it's a well dissectable plane. So it is just much more attached than this nice case Christian showed you, where the tumor basically jumps out of his capsule by itself. Here you have to fight a little bit to actually get a nice dissection. And I'm here. And in the end, we fascicle, which often is extremely small, and you don't even need to cut it. And that's the end of the story. And the patient had no deficit, despite the fact that the function is in that little capsule in here. this is the manifestation of in a median nerve in an NF1 child, which had this large whole median nerve is totally transformed. And we saw these single fascicle lesion where one fascicle really blew up to an enormous size, and he was not using his forehand and arm because of pain. And that is the intraoperative approach. And so basically you need to go in and stimulate, and actually the whole huge tumor here turned out to be not even in the end of sensory importance. It was not a motor tumor, so we could remove all that large part here and got a nice decompression of the arm, full motor and sensory function. We did not address the plexiform neurofibroma in the palm for functional reasons, and he could return to normal hand function because he had no pain anymore. 16-year-old girl, and that is, I'm showing that case because she was told for years that the tumor in the plexiform changed NF1 associated sciatic nerve is inoperable. So she was seen by several pediatricians, the home physician and other people who said that is inoperable, and that was watched for 5 years. And when she came finally, she couldn't sit on her laps anymore because of pain. It was, and it was already quite PET positive. So we were worried about malignant transformation, and you can dissect that out very nicely in the shown technique out of the sciatic nerve. And you already see the beginning necrosis in the center of the tumor. But fortunately, this was still an atypical neurofibroma, as we called them in the past. Now it's an ANNUBP tumor, so an atypical neuromatous neoplasia of unknown biological potential is a pretty long word. I would have preferred something shorter for this type of tumors.
And Martin, I'm sorry, for the sake of time, can you please jump to the conclusions? Because
I come to
presentations to go.
The advantages is we can cure mostly benign and slow growing tumors in NF1 by surgery. There's a low risk in experienced hands, and that is opposite to MEK inhibitors, which don't cure. They must just shrink by side effects. And then when you stop the medication, the tumor starts growing again. And especially pain improves dramatically with very little new motor and sensory deficits. The limitations is that we have a systemic disease. We cannot cure NF1 so far. And this means we have to tell the patient that they will have several interventions, most likely over a lifetime. The problem is the MPNSTs. We need to find them early enough and remove atypical tumors before they become malignant. And most problematic are the plexiform neurofibromas, which are infiltrating the area where we cannot do a total resection. Early intervention is key. There is no suffering necessary on the side of the children, and this needs to be known by caregivers and pediatricians. There are no fears. These tumors mostly can be removed without any problem. The problem here we already heard, and we will hear about the regular screening and the early intervention to get the tumors before they become malignant. And the other thing I didn't touch, but which is very important, the skin plexiform neurofibromas should be excised as early as possible in infant and toddler age when they appear, because then you get away with a small scar and you can cure. Thank you very much. And we published all that recently, and you can also read these results I showed you in literature.
Thank you very much, Martin. We need to move on with the invited speakers. So I'm really happy that we could have Peter Hohenberger from the Sarcoma Center in Mannheim with us. He's an extremely renowned and respected sarcoma surgeon. And in a lot of cases, I asked for his advice and sent patients to him. So I'm really happy that you are with us, Peter. And as the last speaker, well, we will introduce Enrico, of course, because he changed the game somehow. So I'm very happy to have the the bridge now done by Martin, and then we can jump into MPNST. Please, Peter Hohenberger.
Hopefully you can see my screen. Yes,
No, not yet.
I released it.
If you could try again, Peter, by clicking on the green.
Yeah, I clicked several times already.
Yes.
Yes, we see your screen. Perfect.
Okay, so to confess beforehand, if you treat mainly sarcoma, you look probably like someone who has a hammer and everything looks like a nail. So you're clearly a bit biased in what you are, if you are confronted with lesions. So from the sarcoma view, it's a disease of the elderly population. That's the data for Germany. And you see the older the patients, people get, the more sarcoma they have. The red lines are the soft tissue ones, including also the MPNSTs. Age-adjusted sarcoma incidence, 7 per 100,000 in males, and 0.2, that means 1.9% are MPNST. Age onset is not much different between males and females. Females have a slightly less incidence. If you take out the data for the neurofibromatosis patients, then the shift is even bigger. Age median is then at 75, with an NF1 patients roughly at about 30 years. That fits also with the following images. So if I look to our sarcomas who have undergone biopsy, it's close to 400. MPNST is 5.4%. So it's a bit enriched in our population. So coming back to the sarcoma business and to the molecular classification, MPNSTs belong to two subgroups. The one sarcoma subgroup is this with the recurrent translocations or deletions, and that's the NF1 population. I don't tell you much new. The majority of MPNSTs, however, has a complex karyotype that particularly is true for the radiation-induced MPNSTs, and they don't have something that make them suited for targeted therapy. So there are data out there that the radiation-induced and the NF1 associated ones have a worse outcome. That's the data from the Mass General. Highly significant difference between sporadic neurofibromatosis and radiation-induced ones. The Dutch do not so much go along with that. That's the nationwide study. I expect Enrico Martin to talk about a bit more, so I will just show this slide. So there's no significant difference between the NF1 and the no NF1 patients. Where are we confronted with those MPNSTs? At the pelvis, at the head and neck, typically at the tibialis anterior compartment. And the most recent WHO handbook says it's an aggressive tumor with poor prognosis. And if they are greater than 5 centimeter locally recurrent or of high grade, that's adverse prognostic factors. So for a couple of years, MPNSTs haven't been graded. Now they are graded again, not according to the French system, but low grade and high. That's the features of the NUBP, less than 5 mitosis, no necrosis, more than 5 mitosis combined with necrosis. That's called high grade. That's of importance in the sarcoma field because any high grade tumor qualifies for at least adjuvant radiation therapy. So what are the requirements of good surgery for sarcoma, including MPNSTs of today? Imaging, biopsy, pathology, and so on. I will try to move quickly through these steps. With one case, 32-year-old male, neurofibromatosis, had a lesion in the tibialis anterior compartment. You see that it's close to the fibula. So it was on an ambulatory basis in local anesthesia, excised, turned out to be an MPNST, T67, 20%, grading 2, which is according to the French system, had a postoperative plegia of the perineal nerve, but it was an R1 resection with contaminated margins. So 2 months later, he underwent a re-excision at a neuroscience institute. The excision was done in multiple pieces. That's what the pathologists reported. That cannot be oriented. Once again, R1 resection and microscopic tumor cells at almost all resection margins. One is not happy to read that. So another 3 months later, he had another recurrence, PET positive. You see it here on the anterior compartment, and underwent now compartmental excision of the tibialis anterior muscle, extensor digitorum longus, including partial resection of the fibula. That's 1.5 years ago. Underwent adjuvant radiation of 60 gray. And we follow him up with whole body MRI for his underlying NF1 disease. That's the most recent image. It's more to show you that we really took a part of the fibula, we took a part of the tibialis anterior, we took a part of the flexor digitorum, and so he is up to now free from recurrence. So there was a good pre-treatment imaging, but there was no biopsy. That's something I would like to really challenge, and my view of this paper is a bit different. There's no advocate for incisional biopsy. The intention of that paper is to make sure that lumps are not excised without histological proof beforehand. And whether you do it by core needle or by incisional, that's up to the operating orthopedic surgeon, neurosurgeon, or surgical oncologist. The German evidence-based sarcoma guideline, to be published in 2 to 3 weeks, will say that tumors larger than 3 centimeters should have biopsy first. So, how biopsy? No fine needle aspirate, coaxial, at least 16 gauge core needle. That's what we look for. Or better, incisional biopsy. We did a meta-analysis published last year in Cancer, could include 17 studies. And we see that there is no difference on all soft tissue tumors between incisional and fine needle. There is also no significant difference in the soft tissue sarcomas between core needle and incisional, but there is a significant difference for post-biopsy complication rates. And this is clearly in favor of the core needle. So needle track seeding, at least once a week here, one should not biopsy sarcomas. That is not true. We biopsy 8 millimeter breast cancer to make sure it is breast cancer before treatment. Why not biopsying 3 to 4 centimeters of tissue lumps? The needle track seeding risk is 0.1 to 0.3%, depending on the region. And I had a look, and that's the advantage of virtual meetings, to look whether aren't there data on the oncological accuracy of image-guided core needle biopsies. And there is a paper from the US group around Barry Feig, 78 nerve sheath tumors, 19 benign, 59 benign, 19 MPNST. They missed 1 MPNST and had an accurately of the malignancy in 94 of the cases. and schwannoma or MPNST were 100% accurate with core needle biopsy. So how about treatment planning? We all know that in malignancies, we should take it out with clear margins. So if you go do a shelling out procedure, you will end up with R1 or R2. If you do a marginal incision, you might have R1, but you are at least at the risk, have a chance for R0. So everybody says 1 centimeter of margin, but can you do that really? Take it out as a bullet and take a piece of the femur? Nobody will do that. So if you take it out, you will take a part of the sartorius muscle, a part of the rectus femoris muscle, a part of the vastus intermedius, and take a cuff of muscle around the tumor to take it out. And the deep femoral vein is the limit. So metric analysis in terms of centimeters is really not useful. So it might look afterwards like this. You have a clear margin and you make sure that you can close the wound adequately for post-operative radiation therapy. That's from the JCO saying that R1 means tumor at the inked margin. And this is clearly worse than having an R0 resection. If you have tumor not at the ink, but within 1 millimeter from the ink, the difference of R0 to R1 with 1 millimeter goes smaller. There is a group from Bochum, plastic and reconstructive surgeons from Ulrich Steinau and Markus Lehnhardt. They analyzed more than 1,000 patients treated over the last 10 years. And they nicely can show that if you have an R0 margin, it does really not much matter whether you have 5 millimeters, 2 millimeters, or close to 1 centimeter. That are the 3 curves for recurrence-free survival up to 10 years and disease-specific survival with 1 millimeter to 5, more than 5. So bigger margin does not make better results as long as you know what you are looking for an R0 resection. So how about adjuvant and neoadjuvant therapy? MPNST of the sciatic nerve, you cannot, this huge tumor, you cannot resect that with clear margins. So we selected to go for preoperative radiation therapy, resected that in a compartmental fashion, and the sciatic nerve is part of the resection specimen. That does not preclude that the patient can almost walk nicely 4 months later. Okay, if you know where to look, you see that the sciatic nerve is missing, but the loss of the femoral nerve is much more conflicting with the patient's life. So those patients need irradiation with grade 2, grade 3. You see that's once again the Mass General data that surgery plus radiation is better than surgery alone. You also see that preoperative radiation improves the results of surgery alone, and also post-operative radiation improves the results. So at least do radiation better either before or afterwards. So what is the decision to use it beforehand or afterwards? The morbidity of neoadjuvant radiation is significant. It increases the wound healing complications in the randomized study published 2002 from 15 to 30%. But the radiation dose pre-op is only 50 gray versus 60 to 60 gray post-op. And the irradiation field pre-op is 40% less because you irradiate the tumor and not the surgical field. So in the long run, limb stiffness, other morbidity to the limb is higher in the post-operative setting. And so we would clearly prefer pre-operative radiation therapy. That requires biopsy. Other method of Preoperative treatment, if you have an MPNST like this, you want to convert it into a necrotic tumor, that can afterwards rather easily be taken out with preservation of all the tendons and requires plastic reconstructive surgery. You can use isolated lymph perfusion with TNF-alpha and melphalan. I do not want to go into more details here. This is an established treatment, and particularly for the lymph tumors is of major help. Patient with MPNST, same location, other side, 53 years old, prior to perfusion, after to perfusion. It's only an amorph mass. And then you take it out with a chip of the bone, with the interosseous membrane between tibia and fibula, and you have to resect the tibialis anterior vessel and nerve, and potentially graft it if the posterior artery doesn't supply the food. So conclusion from a sarcoma surgeon, basis for MPNST treatment is histology. Biopsy is most often required, even if the tumor is close or part of a peripheral nerve. Only if you can excise it with a chance for adequate re-excision, you are allowed to do it with the tumor is less than 3 centimeters. R0 is crucial. The margins of safety to the tumor borders are essential, and adjuvant radiation therapy in grade 2 and grade 3 are standard. We do not make exceptions for MPNSTs. Thank you very much for your attention.
Thank you very much for the presentation and these clear words. And I can already hear the discussions, and I'm very happy to have as the next speaker Enrico Martin from the Netherlands, because his publication, I think, changed a lot of things in this community, especially with dealing with MPNST and the question of function and non-function. So Enrico, I'm very happy that you are here, and I'm very curious to hear your presentation.
Thank you so much, Christian, for inviting me, and it's an honor to be talking after Peter, and an honor to have me here on the peripheral nerve section for the ENS. So I'll be talking some stuff about the outcomes of MPNSTs, at least what we observed, and we'll take on some different angles on what these outcomes entail, and probably maybe talk about some controversial issues as well. So we've heard a lot about what are MPNSTs, how are they diagnosed, and I think for this talk it's important to think that we're a diverse group, maybe a little bit more peripheral nerve surgeons rather than sarcoma surgeons, but it's important to know that we look from a different angle. A sarcoma surgeon will look at MPNSTs from a sarcoma point of view, while peripheral nerve surgeons will look at it as a malignant form of nerve tumor. And in the end, we're treating the same tumor, or we're diagnosing the same tumor, which is actually just simply a sarcoma, a malignant, highly aggressive tumor originating from nervous tissue. So as pointed out multiple times in other talks tonight, it's a difficult diagnosis, both radiologically and pathologically, even more so for N1 patients. But they are, any MPNST, except for some low-grade MPNSTs, are aggressive soft tissue sarcomas, but do have varying outcomes of patients that die very early on, even in local, with local disease, while others can live up to 10, 20 years after excision has been performed. They do metastasize and recur frequently, more so than some other soft tissue sarcomas, which makes them difficult to treat, and especially treat them curatively. So what we do, as Peter pointed out, is that in principle, we think about aggressive surgery. So wide local excisions has been the standard for any MPNST, but because of their origin in nervous tissue, they can of course lead to disability. So what I want to talk about is a little bit on how do these outcomes vary oncologically, so on survival, and how do the patients present differently, but also how morbid are these resections, because actually we've not heard about this so much because they're very rare and it's difficult to get a grip of how these outcomes on morbidity are found. So at first I want to talk to you about the patients we've seen in the last 30 years in the Netherlands, which includes about 800 MPNSTs, of which 210 neurofibromatosis patients are included, showing the same picture as Peter showed on the fact that neurofibromatosis patients are generally a lot younger than the non-neurofibromatosis patients. And in these adult patients, we have about 85, so about 15% of those patients present with metastatic disease. And as we can see in the bottom right, these have a much worse prognosis on average compared to localized disease on presentation. So if a patient presents with metastases as at first, they will probably have a median survival of 8 months compared to almost 6 years for patients who have localized disease. And splitting these between retroperitoneal and non-retroperitoneal tumors, we know from sarcoma experience that the retroperitoneal sarcomas behave differently than others and require a different approach, both on excision wise as well as radiotherapy and chemotherapy. What we did is on these 600 patients, so the localized adult MPNSTs that are not retroperitoneal, we made a Cox regressional model to evaluate risk factors that affect outcomes. And indeed, although like as Peter showed on, there's a lot of discussion if neurofibromatosis influences outcomes, or at least survival. We see on a univariate analysis that these differences are not significant, but when performing a multivariate model, we do see that neurofibromatosis patients have a slightly higher risk of dying earlier on, so they have more aggressive tumors, as well as older patients, larger tumors that are deep-seated, so quite general confounders that are found in any sarcoma. But when correcting for these patient and tumor characteristics and looking at the effect of your surgery and radiotherapy and chemotherapy, we observed that radiotherapy and chemotherapy overall did not affect survival, or at least was not associated with an effect on survival, which is of course possibly confounded by their indication. But in the overall group, there was not a significant effect of it. Looking at the margin, where Peter talked about the R0 and the R1. So the R1 saying that there are some tumor cells in the margin. And for R1 in this study, we were able to view all 800 patients' pathological reviews because we have a national database of that. And the R1 was defined as tumor cells at the ink, so not a millimeter, but at the ink. And when we compare the patients that had a complete resection, so R0 resections, to the one with an R1 resection, although it seems a little higher, the difference, it was not significant compared when confronting all confounders, but the ones that are excised partially, so the R1 or weren't excised, did a lot worse, of course. And unfortunately, when looking at the time periods, we have not been able to provide a better prognosis for patients, at least the adult patients, in the last decades. But we did another study in children where we did see quite an impressive increase in survival prognosis. And that may possibly be due to the fact that in the Netherlands, we are continuing to provide a specialized healthcare. And in the last 5 years, we centralized all sarcoma healthcare in only one pediatric center. So our group ourselves, we're still looking into the effects on metastasis and local recurrence. but from literature we know that about 30 to 50% of all MPNSTs over time will metastasize, and about 20 to 40% will have a local recurrence. And the most important factors are actually excision by itself, or the local recurrence, the use of radiotherapy, but unfortunately the use of chemotherapy or any other form of therapy has not been shown to affect survival, metastasis, or local recurrence in a localized disease, at least. But I think in the future we're progressing towards better understanding their various biological behavior and going towards a more personalized treatment effect, where we can better provide a patient-tailored approach, where we truly look at the genomic landscape of a patient's MPNST and better provide possible targeted therapies as well. So as we talked about earlier, Nora talked about how the quality of life and the outcomes are for benign peripheral nerve sheath tumors, which is studied more frequently, fortunately. But unfortunately, the effect of quality of life and function after MPNSTs has not been studied yet. So what we did is, over the last years, we made a large collaboration in the Netherlands of all sarcoma centers, and collaborated with the Mayo Clinic in Rochester to provide a large patient sample of approximately 700 patients with MPNSTs, and to look at both oncological and preoperative and morbidity outcomes. And what we did is we classified, at least we tried to find the MRC grading for certain muscle groups post-operatively, and we looked at the loss of sensation, and especially the loss of critical sensation, which we phrased as loss of sensation in hands, feet, or buttocks, because those are used in daily, are the most important parts of our sensation, at least from our perspective. So in our cohort of 658 surgically treated patients, we saw that over 1/3 of all patients had any form of motor deficit post-operatively. And for those that were able to view what the MRC grading was, more than a quarter of all patients will have, more than a quarter of all surgically treated patients will have an MRC grade of less than M3, and which is usually a complete paralysis of a certain muscle group or several muscle groups when talking about a larger nerve. And sensory deficits were more difficult to look into in such a large retrospective data set. But for the ones that we did have information on, almost more than 50% had any form of sensory deficit. And again, a quarter of the patients treated, of which sensory deficits were known, were of critical sensory deficits, so in the hands, feet, or buttocks. Although amputations are not standard of care, because we're in the sarcoma surgery, at least in the last decades, we're moving towards a limb sparing approach. We do see that MPNSTs have quite commonly still undergo amputation. So 61% of all patients with 61 patients with extremities MPNSTs, which is approximately 25-30%, will have any form of amputation. And they are usually quite large amputations. For the upper extremity, most commonly it was a 4/4 amputation. For the lower extremities, it's a hemipelvectomy. So quite disabling surgeries indeed. And indications for such amputations are still quite vague. In literature, we're talking about major neurovascular involvement, but in our experiences, the reason for amputation is largely based on surgeon and center specific ideas on how to treat MPNST patients from their perspective. So we made a multivariate model on what factors are associated with or are expected to have a higher chance of getting a loss of motor function. Again, nerve fibromatosis patients have a higher risk. Patients with tumors in the extremities, in the brachial and the sacral plexus, and those originating from major nerves. So major nerves, it's good to know that not all MPNSTs originate from nerves like the sciatic nerve or peroneal nerve. They can also originate from this small skin nerves, or from nerves that are not distinguishable peroperatively. So only about, I think, less than 50% even originate from a nerve that can be distinguished on peroperatively, or especially on MRI. And deep-seated tumors do worse as well, of course. And it was interesting to see that in the patients that presented with motor deficits, these are patients that are, again, more likely to have persisting or worsening of motor deficit postoperatively. And similar findings are found when looking at the risk of critical sensory loss. So we're talking about a group of patients with aggressive tumors, but with varying results, at least for localized disease. Overall, we have an expected life expectancy of more than 6 years. But a third of all patients will undergo postoperative major muscle function loss, and even more will have sensory function loss. But we know from our reconstructive surgery department that we are able to reconstruct such deficits. But unfortunately, these are actually rarely performed in any soft tissue sarcoma. But they do have the possibility to restore sensation, restore muscle function, nerve function, and even in the cases we reviewed in the literature, may possibly also reduce the risk of neuropathic pain. Because we have not talked about this as well, but neuropathic pain is also a large problem in this group of patients, of course. So in our cohort of 660 surgically treated patients, only 26 patients underwent functional reconstruction, which is less than 4% of all patients that had a motor function loss. 7 patients were nerve fibromatosis patients. Most reconstructions were done, some reconstructions were done immediately at the timing of resection, but most were done in a delayed fashion. From various tumor sites, so from the facial nerve, we did reconstructions, brachial plexus, upper extremity, lower extremity, most commonly the upper extremity, and reconstruction type varied from nerve grafting to nerve transfers, tendon transfers, and free functioning muscle flaps. And important to note is that the majority of patients did undergo radiotherapy or chemotherapy. So I know from surveys, we do know that a lot of surgeons are hesitant to perform reconstructions because the surgical area is a wide resection. There's postoperative complications. There's the use of radiotherapy, chemotherapy. So we are hesitant to perform reconstructions because we think the outcomes are worse. But from literature that is published, the sparse literature that is on this topic, and from other types of cancer, there is no actually there's no basis on why we would avoid reconstruction because we use multimodal therapy. So from these 26 patients, we looked at how the motor function regain was. A lot of outcomes were unfortunately not known, but the majority of patients with outcomes that were known did at least regain muscle grade 3, and some even muscle grade 4 motor function. So yeah, outcomes vary, but they do they are able to restore some, or at least full functional gain of motor function. So in conclusion, the resection of MPNSTs do provide a lot of morbidity. So in my opinion, I think with our results from our nationwide study on the effect of R1 resections in MPNST specifically, I think that is a point of attention that we need to address in future studies, hopefully in a case control study where we can view on how we could possibly provide, at least for lower grade tumors, this aspect, and especially in the form with or without the use of radiotherapy to provide this close margin surgery, because in brachial plexus tumors, the MPNST does not always involve the complete plexus, but a lot of surgeons do tend to remove at least the largest part of the plexus if an MPNST occurs in that region. And in my opinion, that may not also always be the best, or at least the necessary way to provide the best possible outcome in these patients. So, and if one large deep-seated tumors for major nerves are at risk both for oncological outcomes, but also for functional outcomes, and patients that present with motor or sensory deficits with an MPNST are likely to have persisting motor and sensory loss. And we should really provide, in the future, provide the opportunity in a collaboration between sarcoma surgeons, neurosurgeons, and maybe reconstructive surgeons preoperatively to provide the best surgical pathway to find the optimal resection margins, but also provide the opportunity to perform reconstructions either immediate or in delayed fashions, to also not only care for the oncological outcomes, but also provide a good functional outcome for these patients that will likely live the next 6 and sometimes 10 years. So that was my talk. Thank you all for listening, and I'm free to answer any questions.
Enrico, thank you very much for this excellent presentation. And I think there were lots of very important questions raised. So, well, usually when talking about nerve tumors, we end up discussing about the rarest ones, the MPNST. And I think that with the speakers and the different points of view and perspectives we had now, including, and I think this is something that cannot be stressed enough, is the functional outcome as well. And I think everybody of us has experience with patients with an MPNST, and we did something like a, well, tumor or a function sparing access or approach, and nonetheless experienced good survival, or well, good, but comparable survival rates to the R0 resections. So how do we get out of this mess? And when we will do biopsy, and where? So I would ask Fernando to comment on this, please.
As I thought, I think Peter and I agree. Malignant tumors, or probably malignant tumors, should be biopsy. What kind of biopsy? I told you before. We use core needle biopsy, not the needle aspiration biopsy. We don't use that. The problem for me in my environment is the support of imaging. So we have a CT to support CT guided biopsies. They are done by the radiologist, the interventional radiologist. And the other point, I stressed it before, and Peter said, how do you treat malignant peripheral tumors? You need to have histopathology. This is a big point. I would like to know if all of you, I suppose you do, you have a pathologist experienced in tumors of the peripheral nerve system. I have a pathologist that, thanks God, works with that. So the diagnosis is easier and I can trust the diagnosis. But this is not common. I think this is not common, at least in my country. You don't have experienced pathologists in the pathology of peripheral nerve tumors. This is one point. This is one point. The other point is that I told you before, we changed our approach. In the past, because we didn't have a pathologist experienced with that, we had difficulties in doing image-guided biopsies. We had to operate the patients. But from some time now, we never operate a malignant tumor that we think it's a malignant tumor without a biopsy. And why? Because it will change. If the tumor is really malignant, I think we must talk with the patient and the family and say, well, I will have to take your nerve out. I cannot only take the tumor because it will come back. So I think a biopsy is really necessary, but we must avoid at all costs, this is my suggestion, to biopsy a benign tumor. And this is a problem. And this I want to ask back. You have more than 50 sarcomas. And the problem in my head is that we sometimes see patients with benign tumors treated like a malignant tumor. Understand what I mean? I mean, well, let's do as it was a malignant tumor. How? We have received some patients operated elsewhere with negative margins. But when you look negative margins from a schwannoma or from a neurofibroma, and the patients have motor deficit. And when you look back in the case, you see, well, the clinical evidence, so I stress a lot the clinical aspect of your exam. The clinical exam and the imaging you have would point it probably, really probably, for a benign tumor. So you should not biopsy. We have a series of patients with more than 30 patients right now. We are collecting all the cases with complications after biopsies, all kinds of biopsies you can imagine. So, I'm sorry. I fully agree with my colleagues. For malignant tumors, expect to be malignant tumors, a biopsy should be done. And you need a neuropathologist experienced in peripheral nerve tumors. Otherwise, the confusion will be greater.
Thank you. Enrico or Peter, would you like to directly comment on that?
Yes, please. So I think we are not far away out. What you see we see two different, let's say, flips of the coin. You see overtreatment in benign lesions. I see undertreatment in malignant tumors. It's a similar problem with the gynecologists and the uterine sarcoma. They say, okay, out of 1,000 leiomyomas of the uterus, 1 is a sarcoma. Why should I stop morcellation? Because that does not, I cannot do open procedure for all those women. Okay, but for the 1, it's deadly if you undergo morcellation. So that's what I see. I see the patients with the malignant uterine tumors, and the gynecologist sees the women with the myomas. And it is pretty similar for someone who is predominantly doing peripheral nerve surgery. The percentage of MPNSTs will probably be low. And if you have something rapidly growing, okay, you might probably be suspicious. But if it's something there for months and is slowly growing and makes mechanical problems, okay, you are not thinking primarily on a sarcoma. So I think that's the two different angles we see. What you are absolutely right is that this is a chain of people who need to work together. Someone doing the image, someone depicting the adequate area, the radiologist doing the biopsy, or maybe it's done ultrasound driven if you have an ultrasound with contrast media. I would exactly up this all use also. We use that for gastrointestinal stromal tumors metastatic to the liver. You see them by perfusion, better than from anything else. So, but you are only as good as your pathologist is in recognizing what is benign or malignant and the methods the pathologist has. So this is a group of people trying to come together and get the adequate treatment and the adequate diagnosis.
I agree with Peter. I think we should not be too hesitant to perform biopsies, ideally core needle biopsies, as Fernando also pointed out, because fine needle aspirations is especially combined when trying to compare the schwannomas to MPNSTs. They're both cellular type structures, so it's too difficult to diagnose on fine needle. So a true cut biopsy is needed. But I agree, it's difficult to diagnose them on MRI. How do we go from there? So I think we need more research on how we can identify these tumors more easily, or at least make them more probable for malignancy. And in the neurofibromatosis patients, we have the use of PET scanning. I don't think there is a use for PET scanning outside of the neurofibromatosis patients, because schwannomas, especially ancient schwannomas, will also have a high uptake. So I don't think there is a good role for that. But when using MRI, and especially in the centers that are fortunate to have diffusion weighted imaging, the use of ADC values has been shown to provide quite, or at least help in distinguishing both, with about a sensitivity and specificity about 80 to 90%. So combining that with other factors, especially the clinical view, the fast growing, and other to be defined set of factors, I think we should biopsy the suspicious lesions.
Maybe I can add from the pediatric neurosurgeon, or from the neurosurgical point of view. As you already said, we are seeing mostly benign lesions, and I rather, in our own centers, I think we don't have the problem of not becoming suspicious and running into a malignant tumor by chance, because the clinical features, as you mentioned, the MRI features with the ADC values, if you have a dedicated MRI, and you always can do a PET, and mostly it's the clinical features that lead you, the history and the symptoms, to the suspicion of a malignant tumor. I rather see the problem in the periphery. And I think Christian and Nora see it similar. We have these patients which have a clearly benign lesion. Everything is benign. The MRI is benign, and the history is benign, and they are seen by an orthopedic surgeon or somewhere, and they are just biopsy everything. They biopsy everything, and then we see the patients with the pain syndrome after biopsy because they injured the sensory fibers at biopsy, and then we have a problem, and that is the from our point of view. So we lack a good radiologists out there which clearly say, or good knowledge out there which really differentiate is clearly benign lesions, and I don't think that they should be biopsied. But the problem is not in the centers. The problem is and Peter Hohenberger showed a very nice example of a wrong estimation, and the patient is sent to a next institution, and there he has also not an adequate treatment. So in both ends we have problems, and I think we need to get the information out to distinguish between the two entities.
So I think I've been, Anna sent me some messages that we are, getting late. Well, actually, we left out a couple of very interesting topics regarding the MPNST. So maybe we could have, a webinar only on this. I think one, and I'm really happy that we could have all these people together with all their expertise and all their knowledge and capabilities. And I guess this is summing up, as all the speakers mentioned before, that this is clearly an interdisciplinary problem, at least the malignant ones. And that it's not either or, but it's, you know, combining everything and anything to have the best possible treatment for patients. And of course we will fail, and we will treat patients in the wrong way and overtreat them or undertreat them. This is unfortunately inevitable, but putting together the forces, I think, well, maybe it's the time is right to really cooperate and not to talk about the neurosurgeons and the plastic surgeons and the sarcoma surgeons doing whatever. And of course, it's always wrong what the others do, and what we do is the right thing, and so on. So this is, I think this is a very limited way to approach this kind of pathology, and it's the wrong way to approach for the patients. So I'm very happy that we finally agreed on a lot of things, and that we came back to perspectives. So I really like that. And I would thank everybody very, very much for being here all this time, having these deep discussions, having the fantastic presentations. And I really hope, well, this is what everybody says, but I really hope that we will be able to meet in person soon. And I would really hope to, keep this discussion alive, maybe some other time. So thank you very much again. And the last words go to Lucas.
Yes, thank you, Christian. This really makes us very happy that we completed the fifth webinar in peripheral neurosurgery. Importance of the subject of peripheral neurosurgery tumors leads us to, let's say, conclusion that we should make another webinar or webinars regarding different subtopics in peripheral neurosurgery tumors field. So thank you very much for this excellent presentations to everybody. Thank you, Anna, for your patience and continuous support. Anna, Mrs. Anna Reck from ENS, and thank you, ENS, for this continuous platform and and possibility to present our webinars. We'll continue with the series of webinars after the summer holidays in September with ENS webinars related to peripheral neurosurgery. So enjoy your summer. Thank you very much for your contribution, and keep in touch. We'll have a business meeting next week of our section, so we'll decide our new topics and dates for our forthcoming webinars. Thank you very much, and this leads us to the conclusion and to let's say finalize this webinar. Thank you.
Thank you very much.
Bye-bye. Bye-bye.
Bye.
Thank you. Bye.
Bye-bye.
Thank you all. Bye-bye.